recently joined our board at IATA. And he is the director of the Johns Hopkins Center for Humanitarian Health and a professor at the Bloomberg School of Public Health. He has over 30 years of experience in humanitarian health, including senior leadership roles at UNHCR, CDC, MSF, and he currently chairs the Lancet Commission on Health Conflict and Forced Displacement. So Paul, I'll hand it over to you. Go forward with the session.
Should bring everyone up.
Sure, yeah, everyone can have a seat over there. And does anyone have slides?
No slides.
No.
Good morning, everyone. Pleasure to see all of you. You can hear me well? Okay, great. I thought I would maybe just start by giving a brief take on where we are, and then introduce the panelists, and then we will get right into it. This is obviously a really challenging time. We all know that, and I wanted to really, it's nice being academia, no longer UNHCR, so I can speak openly and have and really say what I think. So, we're seeing such an increase in populism, authoritarianism, lots of isms, racism, and anti-migrant sentiment. And this was starting well before what's happening now. We're seeing acute flouting of international humanitarian law, international refugee law, and human rights law. Right before our eyes, we're seeing ethnic cleansing and genocide happening, and I'm sure, certainly, despite being involved and speaking out, feel quite helpless about what's happening in many ways, and sometimes feeling a little bit desperate. We're seeing attacks on healthcare workers and health facilities. It's no longer rare, it's the norm, and in fact they're increasing, and we're seeing an no accountability, and this is happening with impunity. And now we have, and this was all before, now we have since January this massive reduction in US government funding. But it isn't just a massive reduction in the funding, it's an attack on global health. And it isn't just in America, as we know. All the other, particularly Western powers, have dramatically reduced their global financing, their humanitarian financing, and moved it mostly to defense, particularly those who are working with NATO. And who is suffering? Of course, we know of the most importantly, those that are vulnerable globally. And I'm sure many of you read the Lancet article where estimate that 14 million people may die because of what's happening now in the future. But I also, as Sylvia did, I wanted to acknowledge the suffering that's in this room and all of our friends and colleagues who have, on a personal level and a professional level, a lot of uncertainty. And it's going to be very difficult. I'm dealing with so many students, who just graduated, and they're really having a hard time finding positions right now. And it's really difficult. It's difficult to be optimistic at this time. However, I wanted to also acknowledge that the humanitarian system was and is not fit for purpose. It's not been functioning well for decades. And it may actually take something like this to make changes. When I left UNHCR, which was remains one of my favorite professional experiences, and I just love that organization. So I left for a variety of reasons, but I wrote a Lancet commission. I think Bayard, wherever he is, ran this was a special edition where I said the humanitarian system is not just broke, but broken. And sadly, much of what we wrote about then still remains. And as Sylvia said, we're actually just finalizing. So in the first quarter of 2026, we hope to come out with the CHH, Center for Humanitarian Health Lancet Commission on Health Conflict and Forced Displacement. And we're really calling for a radical change in what's happening, not incremental change. And I do believe it's really hard for UN, big international NGOs to make a change unless they're forced to. I think it's probably not even organizational and human nature to give up power, advocacy, and funding to national NGOs and others. And so I do think that this situation, not how it came about and the methods, the brutality and the lack of forethought, but I do hope that there is an opportunity here, despite all of the pain, to actually make a system that is more just, that is much more community-based, locally based. And I hope that it's time as a global community to recognize that the UN and the international NGOs are too big, are too costly, and that we need to have a slimmed down response, and an appropriate response where the communities, the local and national NGOs, and then we're not going to call them governments, but rather just the governing authorities, because they're going to, in many countries, sadly, you've got 2 existing or 3 existing governing authorities there. But those governing authorities that are legitimate and have capacity, that they should be the ones taking over and actually making the decisions. So with that, and with this idea that this is a really painful time, there are also a lot of opportunities. Today's session is really going to be looking at and discussing, focusing on the current situation, particularly the funding, better trying to understand how organizations are dealing with this, both in terms of human resources, in terms of strategies, focusing on diabetes and humanitarian emergencies. We have a wonderful panel. I have their bios here. Teresa Zachariah from WHO unfortunately was just called out, so we found out yesterday, so she kindly videoed her address. So we'll start with her, and online, recorded. So Teresa is a medical doctor and public health expert with over 20 years of global experience in humanitarian health and emergencies. And she leads the Humanitarian Disaster Action Unit at WHO headquarters here. And she previously served as incident manager for WHO's response in Israel, in Palestine, and was the deputy incident manager for Ukraine. She also worked with IOM. And then following Teresa's video presentation, we'll move to Dr. Alan Mina. And so Mina is a medical doctor, good friend, public health professional with nearly 2 decades of experience in humanitarian health. He's coordinated public health responses across Africa, Europe, Asia, and the Middle East. And he's contributed to policy shaping publications. He's the head of health at UNHCR here in Geneva. And he began his career as a government clinician in refugee camps in Kenya, where I think I met him many decades ago. And as I said, he oversees global health at UNHCR. Herb Riband. Herb is the executive director of Access Accelerated, a coalition of pharmaceutical companies partnering with the World Bank to strengthen NCD prevention and care. In 2024, the initiative launched the Financing Accelerator Network for NCDs, FAN, to enhance health financing in low and middle income countries. And Herb has 38 years of global experience, including senior roles at Amgen and Medtronic. And Herb focuses on developing sustainable, locally led financing solutions to expand access to NCD care. And then finally, Dr. Australia Lasry. Australia is a family and emergency physician with a master's in tropical medicine from London School. And she's worked extensively with MSF in the field and advisory roles. She has a lot of experience in humanitarian emergencies. She focuses on malaria and neglected tropical diseases. She was formerly the senior malaria advisor at the Global Fund, and now she's the new role as the senior integration specialist, supporting countries to strengthen resilience and sustainable health systems. And so with that, thank you all for joining. If we can put the video on for Teresa. Tension if this works. Oh, it works. Thank you.
Distinguished colleagues, good morning and welcome to Geneva to those of you who have traveled from near and far to attend this 5th Symposium on Diabetes in Humanitarian Crisis. It is an honor and pleasure to address you today at this symposium, and I would like to sincerely thank all the organizers and sponsors who have worked very hard so that we are all here today, addressing this enormous public health risk in enormously complex situations. Non-communicable diseases, diabetes included, are the leading cause of premature death and disability worldwide. Diabetes alone affects hundreds of millions globally, and in humanitarian context, the burden is amplified. People living with diabetes in humanitarian settings face increased risk of complications and of losing their lives due to discontinuity of treatment, inadequate detection and monitoring, and the stresses of displacement, violence, the loss of connections, and the list goes on. To add to this complexity, this year we have witnessed an unprecedented cut to humanitarian aid and divestment from development, with the health sector being hard hit. This year's Global Humanitarian Overview reflects the severity of this funding crisis. As of the end of September, just 21% of the more than 43 billion needed to support life-saving actions around the world has been received. This is a staggering decrease of over 40% compared to the same time of last year. And earlier this year, the humanitarian community had to make the hard choice of urgently prioritizing the people who are in need of assistance. Of the 81.4 million people initially targeted for health assistance, 43 million are now urgently prioritized. This means that nearly half of those in need are at risk of not being assisted. Decreased financing has profound implications for diabetes care. In Sudan, for instance, 1.8 million adults with diabetes could be excluded from life-saving services. In Syria, roughly 580,000 adults with diabetes risk losing access to care. In Afghanistan, roughly 1.9 million adults with diabetes are undiagnosed. Yet health facility closures have reduced services for nearly 3 million people, and only 59% of facilities providing diabetes services remain fully operational. In the Democratic Republic of Congo, 195,000 adults with diabetes could be excluded from essential services due to this reprioritization. In Yemen, some 720,000 adults with diabetes are not diagnosed, let alone treated, and only 7% of facilities are providing diabetes services fully. In the face of these challenges, we must implement proven, cost-effective strategies. Task shifting to community health workers remains essential, as does integration of NCD services into humanitarian response packages. But even as responsibility is increasingly transferred to local actors and the health system, we really want to emphasize that international support and resourcing must continue. It does not alleviate us from our obligation to provide the support and financing necessary for our local partners to operate. Data-driven planning is critical. In both Ukraine and Sudan, integrating NCD metrics into public health situation analysis directly inform interagency responses, ensuring continuity of diabetes and other NCD care and funding allocations. This demonstrates that when we measure, monitor, and act on NCD and diabetes data, we can prevent avoidable deaths even in the most challenging environments. We can even make our prioritization process more fine-tuned and well-targeted. But most importantly, people living with diabetes and other NCDs must be actively involved in the design, planning, and implementation of interventions that affect them. Diabetes and other NCDs do not wait for crisis to end, and neither can we. WHO remains committed to ensuring that all people, even in the most challenging humanitarian contexts, have access to essential care. Thank you.
Thanks to Teresa. I'm sorry she's not here in person. So next we're going to go to Mina. Over to you.
Right. Yeah, thanks a lot. So good morning. Good morning, everyone. And it's really a pleasure to be here. And thanks a lot again also to the organizers for convening us together. It's really a pleasure to be able to be among good friends. When Paul was talking about how long we've known each other, I was not sure whether it defines how young I am or how rich the friendship is, but it's up to you to interpret that. but we really come a long way. And it's really great to see colleagues and friends, some who've worked for UNHCR in this place and now moved on to other opportunities. But also, UNHCR is also facing the very difficult situation where some of our colleagues have lost their jobs and some of them will be here with you. And it's been tough. It's been a tough time to ensure that continuity of care, healthcare in humanitarian settings is upheld, but also having the right capacity to be able to implement those programs. As presented earlier, the context is difficult with crisis, conflicts, and also climate change getting worse and worse by the day. Despite efforts to address the cause of the conflict, and we appreciate those efforts, we still face a humongous challenge. And access to care and continuity of care is, as basic as it sounds, has been very difficult. And Teresa has outlined some of the shortcomings we are seeing. And it's a double challenge where you see an acute emergency where continuity of care, access to care is limited. Even as recent, we talk about the low and middle income countries, but also in Europe during the Ukraine emergency, we saw Ukrainian refugees who are not able to get continuity of care and resulting in diabetic complications as well. So it is a challenge across the board in terms of how we prepare for emergencies and ensure that even though the registration and also this documentation issues are trying to be sorted out in policy, that they can be efficiently managed to ensure continuity right at the onset of an emergency. As highlighted earlier, more than 80% of deaths being reported for diabetes are in low-middle income countries, where we have more than 70% of the refugees located. And so the challenge is in these locations where we're seeing governments are trying their best to include refugees in national systems, but they're also facing an enormous socioeconomic challenge as well. We're seeing an improvement in inclusive policies, but again, it's an issue of solidarity with the governments who are trying their best to ensure continuity of care. Just to put in context, even before this current financial challenge we're going through, a recent study done together with IADA and also with ICRC, MSF, and also I think it was, and the UNHCR, it showed that with the challenge of diabetes care in humanitarian settings was already there even before this current crisis, with less than 10% of the facilities that were assessed across, I think, close to 30 countries where full diabetes care is being provided. So we already had a challenge in ensuring basic care packages, provision of insulin, diagnostics, continuity of care, patient education, and training. So there were gaps in provision of services in humanitarian settings. And this called for solidarity and working together to address these issues. We jointly developed guidance in 2020, this interagency working group that has various international organizations and academia that really helped to define what we need to do in terms of preparedness and early response and recovery efforts, but also continuity during the protracted settings. And it has proved very useful in implementation. But beyond that also, we've developed some partnerships that have been very important, for example, with Primary Care International to improve training and capacity building and being able to apply a TOT model where we can cascade that training down to the local level and be able to ensure that the healthcare providers, even as we're looking at task shifting, that they are appropriately trained to ensure these integrated services, the clinical tools, the basic tools are available, and the diagnostic skills are also well outlined. These partnerships are important, but they've been affected because of the funding situation. We've seen a lot of international NGOs in our refugee sites having to scale down or even stop provision of care. And UNHCR and our partners, we've been able to try and adapt to this crisis. In settings where we had integrated services within the facilities, within the camps, and also earmarked funding, we were able to see services continue, and we were fortunate to have that. But in other settings which relied a lot on referral care and the services are not easily available or accessible where the refugees are located, we saw increased self-referrals, but also increased complications because of lack of access. So the challenge has been enormous in these settings. The it really exposed the fragility of the humanitarian situation, and also in light of the short-term funding and also parallel humanitarian approach that we've been having in many of our settings that really affected us in some of our sites, our camps. In the midst of all that, what has been encouraging as UNHCR, we've been having this 5-year strategy, and inclusion in international systems has been a key strength of or emphasis in our vision. And we're working on the next 5-year strategy, and it's becoming more important that we look at, one, how do we localize better? How do we work better with national and local actors? And recently we've issued guidelines on localization, where we're looking at a key principle: localization as local as possible, as international as necessary. And that means, and we have examples like in Bangladesh, where we've seen our partnerships with the local actors there has really helped ensure continuity of care, also in Tanzania and other places. And where we have had a reliance on international organizations, we've seen the impact where the funding has affected the ability to provide continuity of care. So we are working with both international and local organizations to ensure strengthening of national and local systems as much as possible, but also realizing the resilience of the communities themselves and being able to work with the community health workers to ensure the services continue. And this brings us to some of the solutions that we're looking at and what lessons we're learning. One of them is on innovation. And in Kakuma, for example, we're using electronic medical records to improve NCD care and follow-up. And some of it is the international organizations working there, like IRC. And it has proven helpful in improving provider care and also data and evidence. And we're seeing some other examples in other locations. I think one of the challenges in making sure that beyond the support to the provider is that these innovative tools can also strengthen patient care management and follow-up. So having tools that support the patient to better take care of themselves and be able to ensure appropriate follow-up and adherence. And this is where we need to scale up that paradigm in terms of our digital tools. And then we're also doing some work with the private sector and in terms of, and we appreciate the work, the support of World Diabetes Foundation and others like Novo Nordisk, who have stepped up their support in strengthening national systems. And we're seeing an honest conversation on how we can improve system strengthening towards sustainability. And some of these models are looking at integration of care. This funding is supporting integration of NCD with mental health, nutrition, and primary health care in general, but also system strengthening and capacity building and climate resilience. So a full package that looks at NCD in an ecosystem. Another area where we're working with the private sector entities is towards, like in Tanzania, around self-care and management, where we're in Tanzania, Burundi, and Sudan, where we're training communities to better monitor their blood sugar levels and adjust their diets and manage medications. And this is proving very important in terms of even in the light of funding cuts and disruptions in services, that patients can be able to have the right skills and knowledge to take care of their own health. Coming to concluding my remarks, it's basically to say that, as Teresa said, that diabetes does not wait for stability. And the crisis means that we need to continue to up our game in terms of continuity of care, not only for diabetes, for the whole NCD and non-communicable diseases management. In UNHCR, it is a priority for us. It's part of our primary healthcare package. Despite the increased focus on communicable diseases, NCDs remains an important part of our work. And then also that communities are the front line of resilience, and this we need to continue to emphasize how we can, the role of the communities in transforming the fragile nature of our health systems and disruptions in services into continuity of care, and they have a key role to play in that. And lastly, it's on the importance of inclusion in national systems, supporting governments to be able to provide services in those remote, underserved refugee hosting areas, and the importance of partnerships with the private sector, NGOs, and other civil society groups, and localizing as much as we can to be able to ensure sustainability. Thank you.
Thank you. Thanks, Mina. I like that phrase, as local as possible, as international as necessary. I mean, one thing that we'll talk about, I think, is we talk about national systems and then integrating forced displaced refugees into national systems. One of the problems is that, or the issues, I guess the challenges will be that those national systems have had now a dramatic reduction in funding as well. So we have to be careful to figure out at least how not to add more burden, because the international community cannot continue to do certain things onto an already fragile and now less funded system. So it'll be certainly a challenge. But Herb is going to talk about that maybe. Herb, over to you. Thank you.
Thank you very much. Pleasure to be here. Thanks to Ayada for the invitation. Thanks to Rachel Nugent, who reached out to me. And Rachel was one of the NCD pioneers who 20 years ago inspired me to really focus on NCDs as a global health challenge. So happy to be here. I'm going to pick up on some of the themes we heard from both Bente Mikkelsen and from Mina. We heard from the very beginning the challenges that we face with financing for diabetes and NCDs and global health. The good news is, if I can use that term, is overseas development assistance for health impacted NCDs in a very minor way. It was less than 2% when to NCDs. It's probably 1% now. So the good news is the diabetes community, the NCD community, didn't lose very much. But the bad news, the challenge, is that the competition for resources are now tremendous. Countries face major gaps which they're scrambling to fill, and this really requires a lot of creativity and new approaches, particularly when we look at the financing angle. As Alan mentioned, I work for an organization called Access Accelerated. You see we're funded by 9 pharma companies, but the most exciting thing about it is we have a technical partnership with the World Bank since 2017, and we're working to help countries improve their health financing for NCDs. And we created something called the Financing Accelerator Network for NCDs, the FAN. One of the reasons I work in global health is because I love acronyms, so remember the FAN, ncdfinancing.org for more information. And we work through regionally based institutions that work directly with countries. It's a strong local engagement model, understanding local needs and priorities, and bringing in global and regional support to help them. We do it in 3 ways. 1, providing technical assistance. 2, creating country-to-country, peer-to-peer learning opportunities. And 3rd, providing catalytic seed funding for promising health financing programs. So that's about the FAN. Many of us in the room here had a very busy week in New York, as Bente mentioned, during the UN General Assembly. And I share Bente's sense of positive vibes that came out of that week. Clearly, there are many challenges, many uncertainties, but I felt a real sense of determination of the community to come together and to really move forward. And really 5 themes struck me. One is about now is the time for country-led efforts to drive sustainable health financing. Bente mentioned it. It was a very strong theme. Now again, not to do it on their own, but with targeted, locally relevant support from global and regional actors. The second is that sustainable health financing for NCDs and mental health is essential. And it really requires 2 things: mobilizing additional resources from a variety of different sources, so more money for health, and then allocating those resources to achieve the greatest impacts, more health for money. Data plays a key role in this. Digital tools can play a key role in how we get there. The third point, which we'll hear more about, is integration of care represents a real opportunity. Integration means between infectious diseases and NCDs, but also looking at the continuum of care, awareness, prevention, diagnosis, treatment, aftercare. And I think Estrella will talk more about this. It's a very exciting opportunity. We also heard a lot about multimorbidities and interconnected conditions. So diabetes with cardiovascular disease, with renal, the whole cardiometabolic space is quite dynamic now. 4th point, we heard that multi-sectoral whole of government and whole of society approaches are essential. We've been talking about it, but now we have to do it. And at a government level, this means ministries of health, finance, but also transport, interior, economy, et cetera. And the last point which Mina made, is that partnerships and multi-stakeholder collaborations are absolutely essential now, including the private sector. So these are some themes from UNGA that I took out. All of these are highly relevant to managing diabetes in crisis situations. We've got to get the basic quality infrastructure in place that will then enable people in this room and many others to respond quickly and effectively when a crisis hits. And this is really what we're trying to do in the Access Accelerator and the FAN. So what does this mean for people living with diabetes? Well, obviously we need to mobilize additional resources despite the many competing priorities. As I mentioned, integration of care represents a major opportunity, and look at examples in Tanzania and South Africa. Pooling of resources is essential. So many countries are either implementing or experimenting with new health insurance models, social health insurance, community-based health insurance, and strategic purchasing of diabetes products and services is a real opportunity. And we know in many places the procurement models are not working well or are broken, but there are new players coming in. And we heard a lot in New York from an organization called AxMed. And there's also the IDA Foundation has a platform called NCD Connect. So these are both looking at insulin and other diabetes products. So what are some strategies specific to diabetes? We heard about the essential role of community health workers, which are scaling up in a number of countries. There's some really interesting work going on to try to create a healthy, sustainable market for insulin. Most people would say the market is broken. What does that mean? There is demand, there's supply, and they don't meet. And they don't provide a sustainable supply of quality insulin that is affordable at the point of care. So there's a few initiatives really trying to look at and create a healthy market for insulin. There's a task ongoing to create an insulin healthy market framework, which will be published as a global good. And there's a coalition of NGOs, philanthropic organizations, and the private sector that are looking to bring that thinking down to a country level. And stay tuned on World Diabetes Day in a month to hear more about that initiative. And if you want to know more, you can talk to James from the Helmsley Charitable Trust. There's also been some really interesting work to create a patient-centric package of diabetes products at the point of care. And that's the key point, is many diabetic patients have to go to multiple places to get the supplies that they need to manage their diabetes. And could we bring it all together in one place so that they can go to one place to pick up the products and the information that they need? So there's something called Diabetes Care Pack, which has been driven by the Coalition for Access to NCD Medicines and Products, that hopefully can scale up. I'll conclude with some reasons for optimism coming out of UNGA. Again, as Bente said, we were disappointed that the political declaration, which has a lot of many positive aspects to it, was not adopted by consensus. But we remain optimistic that it will be approved by majority vote. NCDs, including diabetes, are now firmly on the political agenda. Multi-sectoral approaches and multi-stakeholder partnerships are stepping up and are really delivering value. And countries, I think this is the most exciting part, countries are stepping up and making both resource and service delivery commitments. And we heard a number of country commitments during UNGA Week. And again, as Bente said, a number of countries are saying now is our time to really take charge and control our destiny. But they're not doing it alone. And the single most exciting thing I heard during UNGA Week was Dr. Monique Vletter from the World Bank, who said in the past year, the World Bank has worked with countries to provide $2.6 billion in financing for NCD and mental health services. And that's a doubling of what they were doing before. And 10 years ago, the World Bank's NCD portfolio was approximately zero. So the World Bank, with its vast resources, is stepping up to the game, working closely with countries. And to me, that's a reason for optimism. We now need to work together to really accelerate some of these positive trends that we're seeing, despite all the challenges. Thank you.
Great. Thank you, Herb. Because of time, we'll go directly to Australia.
Hi. Hi, thanks for having me here, despite not having anything on NCDs on the title of the organization. So I work for the Global Fund to fight against HIV, TB, and malaria. And the reason I'm here, so both Herb and Paul already said, is integration. And why does an organization which funds mainly communicable diseases entering the NCD space? So within integration, we've been working on integration for years, but it's become more intentional over the past year, not only due to the current funding scenario, but also due to the needs that have been identified over the years. And even before the beginning of the resource constraints, we had already started including more NCDs within our funding, or countries rather, more than us, had started including more NCDs within our funding, having a more people-centered approach, and because these were the needs that were detected as the need for the people that we're trying to address. So from the GC6, so from the previous funding cycle to the funding cycle that we're in right now, which started in 2024, for most countries, there's been a tenfold increase in the funding for NCDs. It's still not the 2.6 billion that Herb mentioned, so it's gone from 61 million for non-communicable, for NCDs, so for comorbidity, sorry, to 550 million, half of which is for NCDs mainly. And it's part of the idea around integrating HIV, TB, and malaria into primary healthcare, having a more holistic approach around patients, integration around the different platforms for service delivery, but looking at where the patient is coming from, patient pathways, and where the patient is seeking care and for what, and ensuring that that in a similar way to what Herb was mentioning, having all of the care for HIV, mainly HIV and TB patients. Of course, malaria as well, but malaria less related to NCDs and to diabetes, is provided in the same place and at the same time, and also ensuring appropriate referrals to the different levels of care. The other point where integration is already supporting care for NCDs and will continue to support is in the strengthening of health systems. So the department where I work is called Resilience and Sustainable Systems for Health. And that's what we try to do. So ensuring stronger systems for human resources, for health, for lab systems, health financing, supply chain, and data systems. So, as collateral support to HIV, TB, and malaria, with the strengthening of those systems, also comes strengthening for NCD. So even when you say, well, we're not directly funding a lot of the NCD care, we are indirectly providing the support so that either some money from the countries or from other agencies is freed up for NCDs, or it's included as part of the systems care. The other thing both Teresa and Alan and Herb mentioned is the task shifting. There's a lot that's been learned through the HIV care and through the TB care on task shifting, now task sharing. And a lot of the learnings from HIV and from TB, from the HIV and TB community can definitely be applied to NCDs. But I think one of the things that we need from humanitarian actors and from actors working in the humanitarian space is looking at what models of care can serve NCDs and communicable diseases in the humanitarian space. And translating those for NCDs and communicable diseases within the humanitarian space and outside of the humanitarian space. I think there's a lot to learn there because there is an opportunity within humanitarian settings. So in terms of, Paul asked me to ensure I address how our funding addresses humanitarian crisis and how it can be used in humanitarian crisis. And there's three main avenues for that. So one is emergency reprogramming. So in case of emergencies, countries can reprogram the funds that were originally in their three-year grant to be able to address those emergencies, and in those both in conflict setting, what we call challenging operating environments, but it's the global fund jargon, and in areas where populations affected by conflict are entering, and so that's the first use. And countries actually do quite a lot of reprogramming. There's been a lot of reprogramming now during due to the funding cuts, but in emergencies, it's something that countries and recipients of global fund grants do to address the population needs. And there's more flexibility in the use of those funds so that they can address the overall needs of the population. Or as I mentioned, so that money can be free up for other agencies to come in and cover where the global fund money cannot cover. The other one is in implementation of the challenging operating environments policy, which allows for more flexibility, both of the of funding of the operational avenues, but also of what can be in the package. For in humanitarian settings or in crisis settings. There's also access to emergency funding, but that's mainly for commodities and addressing top-ups in needs of commodities, mostly for HIV, TB, and malaria. But again, ensuring that the supply for those packages and the data for those packages gets there also frees up space for funding NCDs. And then funding in non-crisis settings. There's funding in non-crisis settings affected by crisis. A few examples of where our funding has gone to address both NCDs and HIV, TB, and malaria. One would be India, where screening. So in camps, screening for diabetes allowed to identify populations that were would be more vulnerable for TB, with addressing issues of stigma. So there's now it served as a pilot that can be also scaled up to other areas and to primary health care to ensure that both diseases are screened for in the same place, and that care can be provided for both conditions in the same place and at the same time. Bangladesh is another example where with partners we're contributing to include NCD screening and diabetes screening concomitantly in areas with Rohingya population displacement, and that's a lot of that work is being implemented by BRAC and by other NGOs through global fund funds. And another example in a non-crisis setting is South Africa, where drug dispensing is being done for both for HIV, TB, and NCDs in the same place at the same time. So overall, we need more. A lot of the work around integration needs more. We know what needs to be integrated, but we need more on how the integration needs to happen, including for NCDs. And so what we need from the global community is to help us say how to operationalize those funds, how to ensure that those funds are going further, and that they're addressing the needs of people as a whole, including, of course, HIV, TB, and malaria, but also including other comorbidities like diabetes. Thank you.
Great, thank you. Thank you all for staying on time. We're just going to do now amongst ourselves some questions, and then we will be opening it up. I had some questions for the moderators that I shared with them, but they're very bland, and so I'm going to ask some more challenging questions. But since I'm Canadian, I'll do it with a smile and I'll be moderate. So first, for really Australia and Herb, and we talked about this a little bit yesterday, Australia, but you have now, for countries, we want to make it easier for countries, but we have money coming from the Global Fund, from Gavi, from World Bank, from a multitude of sources. And in this time where we need to be much more efficient and effective, is there a way to be able to streamline all of this to make it easier for, we were talking about how, well, the Global Fund may not be able to give money directly for the whole population for NCDs. There's a lot of ways that the NCD community can benefit from this, but the onus on the country is pretty extreme. So are there, what is realistically can we do, and are there talks to make this a little bit more easy for the country itself? And maybe over to you first.
Thanks for the question, because I didn't touch on partnerships, which is key, as you say. So we are working, all of the organizations right now, and all of the global health initiatives are having integration as one of the strategic leads for the next years. Most of us have had it in our strategy already, but now it's more, as I said, more intentional. But we're working towards it. There's been a shock, and we're working towards it and trying to get organized. Of course, alignment of funds would be ideal, and pooled funding would be ideal, but that's not always how many of our organizations work, and they're not, some of the processes are not so easy and so quick to change, unfortunately. But there is one example of that, and it's South Sudan, but it's and Afghanistan in the past, but it's getting there, and it's with all of the challenges of pooled funding. But what we would like, and what a lot of countries are stepping up and doing, is having national health sector plans that address the whole, that have an integration component within them, and that look at where different funding is coming from and where the gaps are. So there's the funding landscaping tables, which look at where gaps in the health sector are, so that donors can more easily identify what needs to be addressed and where are the gaps, and where one organization can reach and where the next one can overlap. And I think it's important to make sure that we keep a very close eye on what those gaps are, and that we continue to urge countries. I think all of our organizations are doing it, and we're very, very consciously doing it, that within those gaps you have to include populations that are in humanitarian settings, so forcibly displaced populations. Of course, there's a lot of work on climate and forced displacement due to climate change, but it cannot only be there, and it needs to be included in the plans that the country is having, and in those funding landscapes.
Let me just, following just one and then to Herb, is that, so you have your funding cycles, Gavi and World Bank, let's just use those three. Is now a time, and how do you think it would be possible, or is it possible, to try to standardize some of these cycles? And who would be able to, I guess it would be the member states or the funders, to like force it? Because it's, as we said, now is the time for change. What do you think is feasible?
So we are trying to align, and we're not. Each organization has different times of funding cycles, different starting times for the funding cycles as well, which makes coordination more difficult. But we are working together with Gavi and with the World Bank to at least identify where those funding cycles align, or where the start aligns, so that conversations can happen at country level, so that some funding requests, some grant submissions can be done at the same time, which forces the conversation in country. But again, if the country is leading, then the country is aware of all of the funding that's coming and the timings of the funding, and the funding just needs to be inscribed in a national plan. If the country is the centerpiece, then we will all align around that, even if our timings are not the same and our processes are not the same. So there is opportunity now for that. It's work in progress, but hopefully, what we would need is for the countries being more open about demanding that, and about ensuring that it's not only on paper, but once the funding gets to countries, the funds are also implemented in a coordinated and integrated way.
Yeah, thanks. Well, I can't speak for the World Bank, but it has been reported that the different components of the World Bank group are looking to integrate their operations, so there'll be greater efficiency. This is IFC, it's MIGA, it's the different entities, so stay tuned for that. But it's encouraging to hear that there's also discussions with the Global Fund and Gavi. I think for countries, how can we make it easier for them? Two things come to mind. One is really start with listening actively to the country's needs. The way the FAN operates is in the countries we support, we have a country core group led by Ministry of Health, but inviting Ministry of Finance, civil society, different groups to really do a snapshot of where is the country today in health financing for NCDs, and what are the most important gaps that they want to fill. And then from that, provide the support. So it's start with a bottoms-up approach and then provide the support. I think countries would welcome that, because they've suffered in the past from top-down approaches that don't necessarily address their local needs and realities. I think what we in the global health community can do is recognize and acknowledge that we've created vertical silos in the past, and when these roll up at a country level, it can be quite daunting. If you look at countries like Kenya and Ghana, where there have been so many great programs, all well-intentioned, but when it all rolls up at a country level, just the sheer administrative burden is tremendous. So I think we all need to make a collective commitment to look at who else is operating in the same space with similar goals, shared values, and how can we join forces? And one of our principles, we call it radical collaboration. We recognize that health financing for NCDs is a huge topic. There are others operating in this space, and we're very happy to join forces where we can achieve a greater impact. This insulin project I mentioned that Helmsley Charitable Trust and Breakthrough T1D have been supporting did an analysis of between philanthropies and private sector organizations in a subset of countries, who's doing what. And again, many, many great projects, but sort of very patchwork here and there. So there's an effort underway to see, can we align our efforts, make sure we're addressing gaps that are there, and achieve a greater impact for people on the ground who we're all supposed to be serving. So I think we can say more can be done at a country level, but we in the global health community can do much more as well.
Thank you. Next and last question to Mina, and then we'll open it up. Mina, it's really following up a bit on the aspect of, since the overall funding is reducing dramatically, HCR's goal of moving towards more and more towards national NGOs, localization, and then also integrating into existing systems. The biggest problem, as we said, I think, is that we went from funding to no funding without a method in terms of our planning of how we're going to actually address that lack of funding. So one of the questions that can be difficult, but I'd like to mention, is that national NGOs may not have capacities, and particularly the admin finance capacities, because we've starved them over decades of just treating them more like consultants, so therefore they get the operational costs but not the admin financing. So what is UNHCR thinking in this 5-year strategy to address some of that? And then what has been your experience as you move in other protracted situations from international to local NGOs?
No, thanks a lot. And you raise a very important point. And we just had our annual executive committee meeting, or what you call a board meeting. And one of the events on the side of that was a meeting or an event led by the refugee-led organizations. And some of the key elements were around that point, that we've seen, we imagine the local organizations as this group of 5 people who have been able to do some consultancy work, some linkages with communities and all that, but they did emphasize the fact that they do a lot more, much less, in terms of strengthening the community health interventions and outreach and empowerment activities. In fact, a lot of them challenged us in terms of how they're involved in governance and looking at more efficient ways of improving administrative and financial elements of the work that they do. So this is something that we are looking at in our localization strategy, and it's a whole organization-wide, not just specific to health. How we can work better in strengthening the administrative and financial aspects of these local organizations, and we're seeing refugee-led organizations stepping up, and some of them also implementing also health interventions in some of our locations that we're working. The challenge is, of course, that in some of these countries where we have challenges with the registration of these NGOs in the national system, and recognition of the civil society groups has been raised. And this is something that we're working with national governments to be able to support not only the local national NGOs, but also some of these community-based organizations, and looking at a social cohesion as a key element, how the refugees and the host communities can be able to work together. Because some of these refugee-led organizations are not just refugees. They actually, some of them have local communities integrated or recruited in the organization. So it's really towards strengthening that social cohesion. And we're partnering with development actors like the World Bank and others to bring this to the much stronger element. I'd like to add just briefly on the point that you said. We're recognizing the challenge that moving towards an inclusion and strengthening national systems is daunting for governments when they are really struggling to meet the various targets in terms of the expenditure, budget declaration, and all these kind of aspects on health expenditure analysis and allocations in their GDP. It makes it even more difficult in the remote locations that refugees are. And that's why we're having discussions with the private sector development actors to be able to ensure that the support to the governments is part of this strategy. And that's why in our 5-year strategy, it's not just about what UNHCR will do, but how we'll support the governments to develop costed transition plans with clear milestones that development actors, private sector can step in to build that capacity for the government. And lastly, it's about trying not to make sure that even the funding that we get from the private sector and all, is not it's less earmarked as much as possible, because earmarking also restricts us. If it's only to NCD and we have essential health services that are needed to be provided, we're having these conversations with the donors to ensure that as much as possible we look at an integrated approach that addresses the primary healthcare needs, essential primary healthcare services, as much as we also meet the donors' interests on NCD care.
Thank you. Okay, so we are going to open it up. There's Stella and Jaggi from IRC who will talk briefly. I think she's online, if I'm not mistaken. I'm hoping.
Yes, I am. I hope you can hear me.
Yeah, thank you, Stella. So you're from IRC, and thank you wish you could be here in person. But we want to ask you how funding changes impact IRC programs and priorities, including the identification and prioritization of life-saving care.
Yeah, thanks. And happy to see everyone calling out of Nairobi. So I'll just briefly share what how our experience has been. Obviously catalyzed by the stop work order of the USG funding, but the reality is we have been facing funding cuts across, even from different donors. And that has led us to really try and reimagine the humanitarian resetting. What will this look like in the future? So, in terms of when when this really happened in after the USG funding cuts and what this really meant for us, you can imagine we had about 39 program terminations happening across our different country programs. We had a lot of delays and confusion, particularly on the communication, on waiver communications, and this really led to inconsistent service resumption. And this went even beyond because we also do implement our programs with also private sector. So even the co-funding from that side was affected, and it disrupted a lot of livelihoods and service continuity. And we also had to juggle with, in different countries, the legal positions on termination of staff, laying off of staff, and the kind of services that we would have to continue and what we can't. So obviously with the communications that we had on the waiver-based approach and having to come down and decide what is life-saving care, this was we had to go back and, like I would imagine, like other INGOs, we had to look at our internal triaging system based on the data that we had, the programs that we had, the populations that we served. But specifically, we really focused on services that would look at risk of mortality and severe morbidity. What would services that would ensure continuity of care of critical health services, and also look at alternative providers, and also really think about community dependence. So the services really varied. Life-saving care varied across countries. Some didn't even prioritize NCDs, even including diabetes, probably because they didn't have that data, and some did. We had countries like Jordan who really went even deep into looking at disabilities, NCDs, mental health and psychosocial support. Countries like Nigeria would focus on more on vaccinations and epidemic control. So this really varied. We're still trying to juggle that and trying to, as we continue with this phase, we know some of our programs are coming to an end in this fiscal year. So also the future is not too clear, but what we are trying to do is based on our health strategy that we've had to sit down and relook again and ask ourselves, what do we really want there? Like other organizations, integration is very key, integrating financing models. We need to move from siloed approaches. We really need to leap our digital systems. We need to look at our partnerships and how that looks like, and particularly localization, as has been mentioned by a lot of speakers, and really working at subnational levels with the Ministry of Health, but also even within our own health clusters as we look at other INGOs. How can we work together? And this was a discussion that we really had on the sidelines of ANGA in the event that we co-hosted with IADA. How do we work together as humanitarian implementers to ensure that we do not duplicate work, we support each other, understand what other people are doing and what is it that we can come in and put in. And also looking at communities, the patients themselves. We are trying to advocate and pilot programs on self-care that are either patient-driven or community health worker-driven, and also looking at multi-sectoral collaboration with our economic livelihood programs. So that's just a snapshot of how we handle the situation, and it's really a lot on this space and what we are trying to do. Thank you.
Thank you. Thank you, Stella. Okay, we're going to open it up. Questions, why don't we take 3 questions, comments, and then we'll hand it to the speakers. So do we need to you got, okay. Yeah, so anyone please put up your hand. There's a bunch. And I'm going to let you choose.
Thank you very much, and very interesting. So my name is Hisham El-Berri. I'm from the national level country. I came from Libya, and I really liked, Paul, the example you gave, when focusing maybe on the World Bank, Gavi, the Global Fund, but I can include maybe other donors. We all know, I can see Estrella mentioned that country is a central piece, which is like through, and countries should be aware. We can see that a global level also it has like high responsibility. This is what you said, and this is also, I think, a big component. But we are all aware that at the level of the countries, so mainly in humanitarian setting, there is no health development plan. There is nothing, the core, to be, based, or the starting point. So do you think that, we know that there is the health sector coordination mechanism at the level of the countries. I don't know, you are aware about that. There is the nexus, what we call the nexus at the level of the but do you think that we need a kind of mechanism? Because having all these donors, silo, as you mentioned, everyone, working with a few agencies, and this is a vertical approach. Do you think that we need to think about a mechanism, a new mechanism, or using what exists already? So, or maybe thinking about champion or agency who can coordinate this work at the level of the country, because we are doing all this to implement at the level of to have impact at the level of the countries.
Thank you. We'll take another. Let's go maybe back to the middle down there. And I would add also, Hisham, with Libya and Yemen, where there are contested areas, you have different authorities running different parts, so it makes it even more complex and important. Please.
All right. Thank you very much. I have a question. You mentioned at the beginning of the session that the current humanitarian system is not fit for purpose, and it should be locally led. So basically moving from a top-down approach to more of a bottom-up. And now, in the UN in particular, we have this big UN 80 initiative or reform. So do we have an opportunity here to make it happen with this big initiative? Thank you.
Just introduce yourself too.
Sorry for that. My name is Eric Dupont, and I'm from MSF Denmark. Sorry for that.
Thank you. Rachel, why don't we go right beside, and then we'll go to your gentleman, and then we'll stop.
Yeah, thank you. Thank you to the panel, to Paul and all the panelists for the really fascinating discussion. Thank you to Herb for being here and for calling me a pioneer. I was once called an OG of NCDs, and I didn't know what that meant. I thought it meant old goddess, but that was 10 years ago, so now I'm an older goddess. My comment, and I'm going to try to make it a question, is about the issue of transparency. I really appreciated the discussion that Paul started about coordination of financing and of donors, but transparency is really critical to that too. And back in the day when I was a younger pioneer, and we were trying to come up with numbers about how much donor financing there was for NCDs, it was really hard. Really, really hard. You had to call people and beg for information, and what was available publicly was quite difficult to decipher. And I see the financing for NCDs and humanitarian crises as a microcosm of that. We've come a long way on the broader NCD financing knowledge base, but we don't have much for this particular subcategory. So what I want to urge, and here's the question, I'll make it a question, is what can you do, in the spirit of Bente, what can we all individually do, what can you do in your institutions to increase transparency of, particularly I'm asking about financing and funding information. We all know that knowledge is power and people keep knowledge close, but it's much more powerful to share what you have and what your institutions have. So any answers or comments or suggestions or inspirations about that? Thank you.
Thank you. And just for this round, last. Anna's coming. And you're not an old goddess, you're just a goddess.
Thank you very much for this important session. This is Zuhair from Onawa. Actually, it's a comment rather than question. And thanks to Hisham for raising this important point, how to control the funding streams. We might have too much money coming in, but we don't know where this money goes, because we do have, my point is actually, we have too many organizations competing for the same dollar. And this is actually in cases of for diabetes care in a humanitarian setting is doing harm more than good. Because it's always good to have too many people work within the same field, because creativity, initiatives and things like this. But end of the day, what we need to have is a comprehensive care for such patients in the humanitarian crisis or humanitarian settings. But having too many organizations compete for the same dollar, this actually causes some sort of partitioning and division in the service provision, which actually does harm for the patients rather than good. Thank you.
Thank you, Zohair. Okay, we're going to start with you, please.
Yeah, there's quite a bit to unpack there, but in terms of a new mechanism to coordinate global health support, I think in today's climate, coming up with a new global coordination mechanism may not meet a warm response. But I do think there is a lot that each of us can do. Coming back to Bente's point, what can you do? Let's start with the initiatives that we're all involved with and look for coordination. And again, I'm seeing that happen. You're seeing greater attempt at coordination within the World Bank Group. On the financing issue, the World Bank and WHO came together and have run a series of dialogues on sustainable financing for NCDs and mental health. And that happened thanks to Bente, Monique Valletta, and others saying, we're going to make it happen between our two organizations. We're not going to wait for a top-down order to do so. We're just going to start doing it. So I think we all need to take charge of that agenda and show the benefits of a coordinated approach. And there's a lot that we can do. Questions about transparency, it's a big issue. I know, just in diabetes, just trying to understand where money was going into a single country, it's taking an enormous effort, and you run into issues like confidentiality in some cases. But I think there are efforts to both gather the data and publish it. Certainly in our organization, any grants that we make will be publicly available in our impact report and on our website. So I think the takeaway to all these questions is we each need to start with what we're doing, reach out to similar organizations, and model the kinds of behavior we want to see and hope it becomes contagious. The other thing about data and transparency, it's a big challenge at a country level where there is money for NCDs. It's earmarked for NCDs, but it doesn't go into NCD prevention and care. It disappears somewhere into the system. So one of the projects that I think we'll support in Kenya is to really track that money from whatever budget it comes from to NCD care at the patient level. And Rwanda has developed a very nice health information system that does precisely that, and it allows informed decision-making. What's having an impact? Where are the gaps? So I would love to see other countries benchmark off of Rwanda's experience and look to build something similar.
Great, thanks. I'll touch a bit on the UNAT, and you're right. It's Eric. It's an opportunity, and we should realize that. But it's not a solution. It's going to help improve efficiency, administrative bottlenecks, and really align mandates and geared towards country support. Yes, and we're hopeful, and it's heading in the right direction. There was a good conversation with member states yesterday, led by the Secretary General on this issue. But I think if we link to what I said earlier in terms of our approach, and also link to what Zenin said about various organizations competing for the same dollar, that's why our strategy, for example, for UNHCR in humanitarian settings is geared towards support to the national systems. The money doesn't have to go through a UN agency. It needs to be directed towards supporting the government. It becomes more challenging in the context where we have different national authorities, and therefore we need an interesting and honest conversation with the actors to be able to ensure that the systems are strengthened in a way that is coordinated and efficient, and there's some accountability. So it's easier in some countries, it's harder in others. It's like Uganda has developed a plan on how to support the humanitarian response. and it's clear in terms of health where the gaps are. And then actors are required to just support that plan, and everyone can be able to we can be able to see what funding is going to different sectors. It's harder in terms of transparency. UNHCR is transparent in terms of the funding that we are receiving. Our systems become harder when we go down to disease-specific transparency. And some of the work that we're trying to do with the World Bank, we've done a study on costing the provision of healthcare services through national systems. We're trying to get a step further with some countries to look at costing at country level in terms of different services. And this is an interesting area where we think if beyond global analysis, the contextual costing elements and financing elements will be an interesting way to go so that we can ensure more efficiency and accountability as well. Thanks.
Yeah, thanks for the question. And I agree, Hisham, that there is still a huge siloing of where the funding is coming from, and ideally we would have something like an integration pact across different agencies that would help bring all of the funding together and streamline it. But we're not there yet. And I think the shock of the funding cuts has been. If there is a positive thing that's coming out is, yes, we're very aware that we need to move fast, we need to move towards more integration and better coordination, it's clear. But agree that having an extra body to manage that would just add to the already quite high bureaucracy, and we just need to find a way to do it. That's why countries leading would be the ideal way, because at least at country level, it's the country that coordinates. It would be more sustainable. We wouldn't be building another international mechanism to manage that. So, but ensuring that the funding can also reach communities in humanitarian settings, because that continues to be a huge challenge. In terms of the transparency, I completely hear you, Rachel, and thanks for bringing that up. We try to be as transparent as possible, but navigating global fund budgets is not always the easiest thing to do. The easiest thing to do is not even getting close to what it means. But we do have a few reviews that look at where the funding is going. So UN Foundation has done, I think for 2 funding cycles, has looked at more inclusion of humanitarian settings in global fund grants. And there's an increasing trend, which is a good thing. I think the fact that a lot of us who work at the Global Fund come from the humanitarian world also helps in that. But there is a conscious decision from the organization, as well as increase in crisis that kind of gives us no other choice. And then UNAIDS and Global Mental Health Initiatives did also a review of funding going to integration of NCDs. In global fund grants, and that's where the data that I mentioned earlier of the increase in funding from 61 million to 554 million for comorbidities came. So it's slow, but it's getting there. And I think given the focus on integration, there's going to be more requests to ensure that that's very clear when we do our reporting, when we do our results report. It's currently very HIV, TB, and malaria focused, but with the focus on from HIV on longevity and on including NCDs, and with the focus on integration as well, we will be again more intentional in being transparent about that. But it's slow. It's a bit slower than we would all like. Thanks.
Great, thank you. We have 2 minutes left, so I'm going to end this by saying we actually are going to end on time, which is the first time that's ever happened for me.
You're in Switzerland.
I'm in Switzerland, yes, the trains run on time. Maybe just one comment, and then one comment in terms of the transparency. We did some work a while back in South Sudan. This was still when you had the Health Pooled Fund and then the Multi-Donor Fund. Health Pooled Fund by, supported by UK and others, and then the Multi-Donor Fund. that was World Bank, and on top of that you had the and that was meant to be long-term development, 5 years, but realistically it was just emergency funding. And then you had all the emergency funding coming in, and it was impossible to know. And they started to look at this at the national level, and that's where I think it's a bit of a mistake to start figuring out what's happening at the national level. I think it may make sense, and at least it's more feasible, so I think Herb was getting at, is maybe look at a district level or other levels where you see actually what is happening and where the fund should go, and then maybe go back to understand what was supposed to have been done by the various donors, because at least in the humanitarian field, what happens at the national level, and I'm sure it's the same with NCDs and non-humanitarian, you don't really know. When you look at the national and you see it trickle down, it's not straightforward. So maybe looking at a lower administrative level could be more interesting. And then I meant to say this at the beginning, but I want to really thank Ayada for setting this all up. I'm really honored to become a board member, and I'm just really impressed with the organization. So thank you all, and I think it's time for a break.
2 quick minutes from me. Thank